Hello, today I'm here with Dr. Candrice Heath, who spoke at the Racial Disparities Deep Dive for LiveDerm on pediatric dermatologic conditions, including atopic dermatitis and scalp conditions. Dr. Heath, can you highlight some of the systemic issues that contribute to a lack of knowledge about atopic dermatitis in patients of color, particularly in the pediatric patient population?
Oh, sure. For atopic dermatitis in the pediatric population, particularly in those with skin of color, sometimes it can be under-recognized. So often in our traditional textbooks in both pediatric medicine as well as dermatology, often the features that are more commonly recognized and talked about are erythema, pinkness on the skin, etc. And some of those very subtle findings may not be recognized in those kids who have skin of color. So what we are also, trying to do is really spread the message that atopic dermatitis can look different in different skin tones. And as a result of that, hopefully we can get kids to see dermatologists or receive treatment sooner than they normally would. The research is also showing us that, with atopic dermatitis, the patients who have skin of color, particularly our Black patients, are the ones that go on to have the most severe types of atopic dermatitis. And so that is another reason why it is great to really recognize the disease early so that we can really close that disparity loop on getting treatment.
Dr. Heath, can you discuss some of the more common hair and scalp conditions that are also seen in pediatric patients of color? And can you expand on why they're more commonly seen or may have more severe symptoms?
Sure. Two come to mind. One is traction alopecia. Another is tinea capitis. I think those are the two most common issues with the scalp that I see in children with tightly coiled hair specifically. And with traction alopecia, this type of hair loss is a biphasic type of hair loss. That means that in the beginning, the symptoms and what we're seeing on the scalp can be reversed. But then in later stages, if the practices continue, then that definitely becomes a permanently scarring type of hair condition. So with traction alopecia, it is really directly related to how tightly the hair is pulled into various styles. And if we go back to the structure of the different hair types, those who have more coily hair, more curly hair, more tightly curled hair, it is more difficult to comb through without causing breakage. And in fact, there is an inherent nature of the hair to be both dry and also prone to breakage. So when you're manipulating the hair into various styles, then that traction can occur, pulling on those areas of the scalp and actually leading to hair loss. So of course, pediatric patients, they're not really able to select the type of hairstyles that people put on them. But of course, they can say, ouch, that hurts, or they can cry because it's too tight. And sometimes it's just sort of like a rite of passage, with people with tightly coiled hair that, we were taught that, we just had to sit still. And that's just what came with having, this type of hair. So often people who, often what was happening is that things were being passed down from generation to generation of hairstyling. So that's why people kind of do the same thing they do for their own hair to their children's hair. And then that's how that happens. So in the pediatric setting, I actually have an opportunity to break that cycle to say, wow, this is traction alopecia. And we really want to focus on saving your baby's edges, which is a common term used on social media. And that tends to get people's attention because we do want your child to have as many options as possible when they become an adult of how they want to wear their hair. So that's one thing. And then the other most common scalp condition that I see, particularly in Black school-aged children, is tinea capitis. So tinea capitis is actually a fungal infection of the hair and hair follicle. So with this condition, kids may develop, scaly areas in the scalp. They may, develop those more classic coin-shaped or these angular-shaped plaques in the scalp. They may have hair breakage, they may have hair loss, and often, yes, I mean, I'm a board certified pediatrician as well as a dermatologist and pediatric dermatologist. So I'm very well versed in what they teach us in pediatrics. And so lots of pediatricians are able to really pick up that, yes, this child could be having features of tinea capitis, but sometimes the presentation that really trips a lot of docs up, dermatologists included, is the seborrheic dermatitis-like variant of tinea capitis. So for the listening audience, that looks just like dandruff. But we know that dandruff, we really don't really see dandruff or seborrheic dermatitis until closer to puberty, after puberty. So if you're seeing something that looks like dandruff in a 5-year-old, then in the right demographic, Black child, 5-year-old, then most likely you definitely need to include tinea capitis or ringworm of the scalp on your differential. Examine those occipital lymph nodes. If you have occipital lymph nodes present, if you have some hair loss, and you have that flaky scaly, it usually is a slam dunk that that child is going to have tinea capitis.
Expanding upon that, are there any unique considerations that must be taken when discussing these conditions with the parents and caregivers of pediatric patients in this population?
Oh, thank you so much for that question. And sometimes, I take it for granted that, you just sort of do what you do, right? And so you just kind of practice medicine, you take care of patients. And what I recognize is that, people would come to me and say, oh, this visit is going left, we need some help, or, oh, this parent is upset. And, all throughout my career, even when as a resident, I would always they contact me to walk into these situations that are a little bit uncomfortable. And now I've decided to really start writing about how do I do things. And one of those things is to really, how do you talk to a parent about something that they're doing to their child's scalp that can then lead to hair loss. And although, people kind of, hesitate to say, oh my goodness, I don't really want to have this conversation, right? It takes a long time to get the hair the way that often parents want it to look. So now you have to tell them, oh my goodness, you need to kind of amend some of the things that you're doing. So really what I like to teach my residents by modeling is that, I compliment the patient and the patient's parent on, how beautiful the hair is, how unique the hair is. Hey, I love your barrettes, things like that. So I really try to compliment them first. And then I bring the parent over to the bedside and we talk about, I point out some of the things that they should recognize on the scalp, begin to recognize to show that some of the ponytails, some of the things may be too tight. And so we look at those together. So we have a discussion about that. And then finally, I would recommend some things that they can do to try to prevent further traction on the scalp. So that is a method that, I kind of called my compliment, discuss, and suggest. You compliment, that way you kind of form a partnership to say, oh yes, hey, I've recognized the beauty in this. And then you want to have a discussion about the longer term impact on the hair follicles, and then kind of make some suggestions about that. So that is a simple technique. So I tell people just, don't freak out. Just remember those steps and you should be okay having that conversation.
Wonderful. Now, circling back to atopic dermatitis, can you tell us anything about which treatments for atopic dermatitis have been studied specifically in patients of color? And do you know if any of these treatments have been studied specifically in pediatric patients?
Oh, that's okay. So that's a good question. So, clinical research studies are typically available to patients of all skin tones, right? So in order for drugs to get approved, they have to go through the approval process and shown to demonstrate efficacy, and then those drugs are approved. So some of the drugs have been around for so long, like topical steroids, for an example. I couldn't tell you like what the ratio breakdown of, for those studies, years and years ago. But I do know that now there has been this renewed zest to actually have clinical studies actually reflect our population, including studying patients who have skin of color. Now, I can probably do a whole, series on kind of the relationship between communities of color and clinical and research, because there have been lots of research studies that have not been good over historically. So it definitely takes some explaining about why participating in clinical trials is important, and this is one of them. So we know we started at the top of the hour talking about how different atopic dermatitis can look. But if you do studies on kids who have atopic dermatitis trying to get your drug approved, the measures that you're using have to really incorporate skin of color. So we know, for an example, once that atopic dermatitis flare resolves, it may resolve with hypo or hyperpigmentation. Is that an adverse event of the medication? No, it isn't. It is just because of the skin has more melanin, and then that is its reaction to inflammation. But if you're really not thinking about that as a researcher, how do you capture that? Oh my goodness, are they going to be counted as, not doing well or doing well? So overall, yes, people doing clinical research studies are becoming more savvy to know that yes, atopic derm looks very different. And if we're doing clinical studies, we do need to include those with skin of color, particularly with atopic dermatitis. If I read a study and the patient population was 80% white patients, that's fine. But this is a condition that predominantly affects those with skin of color. So I always like for the studies to really try to recruit new clinicians, new dermatologists to do clinical research who already have a trusting relationship with their patients, so that we can also participate in those trials to get some of those things approved and make sure that they're efficacious, that they are going to not have any side effects in those with skin of color. So yes, they are doing a better job. There are medications out there who definitely have been leading the way on that, and there are a variety of them.
Wonderful. Thank you, Dr. Heath. Is there anything else you'd like to add before we conclude the interview?
It is important that all of us, all people in medicine, consider healthcare disparities, consider reading about it, consider what we can do to insert ourselves into programs, into new initiatives, or even if it's just to kind of think about things a little bit differently, so that we can close the gap on health disparities. And also really would like to promote health equity as well. So when I am prescribing medications for patients, I'm familiar with research that talks about people from different demographics, different socioeconomic levels, and how that situation at home may be. As a pediatrician turned dermatologist, I know that a lot of kids' parents are divorced, or they may go between various houses. So really accommodating our requests, including all the players in the game, when you're trying to get that patient better, it's going to be very, very helpful. So just asking a few additional questions can actually impact treatment adherence among all patients. Just thinking about how is every patient's life a little bit different outside of my exam room, and what can I do to accommodate that to make our end goal better and easier to reach.
Wonderful. Thank you so much for your time, Dr. Heath. It's been a pleasure speaking with you today.
Thank you so much for having me.